Can you guys hear me okay? Yes, no?
Yes.
Okay, thank you. I'll get started here in just a minute. Dave, I'm not sure if you can hear me, but if you can you enable screen share? Or maybe it already is.
Hey, Michelle.
Hey,
yeah, I'm
how's it
around for a
going?
bit. Good. Screen share. That was what I was trying to work on.
Okay,
I got here early to do it, and then I didn't.
you're good.
You should be able to do it, I believe. Go ahead, see if you can try. Screen share. It looks like it's on.
Let's see. Yeah, it looks like it's good.
Nice try.
Okay. Can you see my screen?
Yeah. Now, Michelle, I really appreciate you doing this today. There's just that
Sure.
one piece I thought would be really nice to kind of cover before the course, just to kind of give the mind some time to think about it and gel on it.
Yeah. Okay. Well, we'll go ahead and get started. So if you guys didn't see Dave's post on the discussion board, he's out today and Eric's out. They're both traveling. I most certainly did not volunteer to do today's course. So we'll see how it goes. I honestly I don't think I've ever talked to a group longer than like, I don't know, maybe 15, 20 minutes. So bear with me a little bit. Today we're going to go over doing like a thoracic scan. So I'll pull up some of Jim's videos. We'll go over how Jim likes to go through his thoracic scan. When we go into the weekend course, I'm sure Eric is going to go into more detail, kind of what he does. I'll talk today on kind of what I like to do too. There's some things I might add, some things that Jim does that I don't necessarily take a look at. So we'll just kind of work through it. For a thoracic scan, I'm usually doing these on patients. It's like a quick little screen to see if I need to dive deeper into more of a like a biomechanical exam for the thoracic spine. So your cervical patients, your lumbar patients, your shoulder patients, for sure, you're looking at the thoracic spine. And this is like a quick little way kind of see where you need to start. So I'm going to go ahead and share my screen. Okay, can you guys see my screen?
Yes.
Yes,
Okay.
you can.
So we're gonna first go through just doing some observations. So I'm gonna go ahead and play this video This is of what Jim's kind of doing, and then we'll go into a little bit more detail. I hope you guys will be able to hear and see this. I don't know if you guys can't see it.
We can't hear it, or I can't hear it. I don't know.
Yeah,
Can you guys hear
no
it?
sound is coming.
Oh, I don't know how to get it playing sound on your guys' end. Maybe I'll turn it up a little bit more. You guys don't hear it?
No, we don't. You could post the link in the chat, Michelle, and then we could maybe all individually pick
That
it
is a
up
good
from here
idea.
and watch it.
That's a good idea. Let me try to do
Also put
that.
like the closed captions on and we can like read what he's saying.
Okay, yeah, let's actually do that because I'll kind of talk through it anyway. So let's do the closed captions. I'll mute this.
The notes from the video are all on the page in the Moodle site under the book.
Yeah, it's on the thoracic. I think it's on there.
It should be in the link I sent out this morning. And what I did was we went through the video and I took all the things that Jim said and I made notes and then we put in some additional comments.
Yeah. So that's what I'm kind of basing it off of too. We'll go ahead and play this and go through a little bit point by point. So just starting with observation, I'll let you guys kind of read through a little bit of the closed captions and I'll pause it as we go through it as well. So yeah, Jim's just saying that you're definitely probably going to need to go through a cervical or a lumbar exam if you're getting some pain into those regions.
Go ahead and pause on that and talk about that a second, Michelle.
Yeah. Jim, oh, go ahead, Dave.
Nope, go ahead. This is the Michelle show.
Jim's talking about just looking obviously at the curvature in the spine, looking if they have too much of a kyphosis or too little. So what would you guys see if you're seeing an increased amount of kyphosis in the thoracic spine? What else would you see as far as cervical or lumbar, shoulder kind of position? I'm going to try to get you guys a little bit involved as well. So tell me what you guys typically see.
You probably see like a forward head with the extension somewhere in the mid-cervical spine to compensate for it, and then like the scapula kind of protracted forward a little bit.
Yeah.
And maybe also superior.
Mm-hmm. Yeah, definitely. What about in the lumbar spine?
I probably see also like maybe some hypertonicity through the extensors.
Mm-hmm. Yeah, a lot of times you'll see like it's gonna try to want to compensate, so you might see a little bit more of a curvature in the lumbar spine, more of that lordotic kind of curvature. But yeah, definitely getting into the forward head. So this is, where you can start with your cervical patients. You're not going to make that much of a meaningful difference if you don't fix the kyphotic curvature in their thoracic spine. They're going to be constantly fighting that. So you can't just stick with the cervical spine if you're having somebody come in with suboccipital headaches and they have this really rounded kind of posture, forward head posture. It's also a good kind of place to start if the cervical spine is almost too hot to touch. It's a good way to kind of lead up to the cervical spine, work on thoracic. A lot of times you'll get some, get stiffness or issues going on with the thoracic spine, but it's not necessarily painful. So it's a good kind of place to start. I'm gonna go ahead and keep playing it. So if they're hypokyphotic, a lot of times you just see a straight spine continuing on down into the lumbar spine. Jim's kind of checking to see if there are any scars. Hopefully, a patient would tell you if they had any kind of major surgery or injury going on. Looking at tone differences, especially in those like paraspinal muscles, seeing if there's more tone on one side versus the other. And that will play a big role going down into the pelvis as well. So you can get, like we'll talk in later modules on how you're getting SI joint issues that's driven for more of a thoracic issue because it's just pulling up on the pelvis. So you can palpate down. Eric will get more into this on the weekend, seeing if you can actually feel some atrophy in the muscles or hypertonicity. You could get either. So looking at the side view, trying to, look a little bit more at their curvature if they have a overly kyphotic or overly flat spine. You can kind of see how it plays a position with her head and neck too. Just, I think it's Beverly. I think she's the patient in this video. She has looks like a little bit more of a forward head, kind of rounded shoulder kind of posture. So from the front, looking at clavicle position, seeing if they're staying relatively horizontal. Looking for asymmetries for sure. Looking at pec tone.
So what would you look for in the front, Michelle? As far as
Um,
clavicle, maybe rotations, how would that influence what we may see in the back?
Yeah, so I mean, obviously it'll play a big issue or it can play a role with the shoulder, but sometimes it's a little bit easier to see rotation from the front versus the back. You might see like a shoulder that's a little bit more forward. A lot of times I'll stand behind a patient and have just my hands resting on their shoulders and see if one feels a little bit more forward versus the other. But a lot of times from the front, I'm looking for that clavicle kind of position, looking for shoulder just elevation. You can look at cervical position. Are they side bent or rotated a little bit more one way versus the other? From the back, Jim didn't really touch too much on this, but I'll actually, feel the scapula a little bit more. I know this is getting more into like palpation, but I'll actually put my hands on like the inferior angle of the scapula. And obviously, you're just kind of looking for symmetry. If one feels a little bit higher than the other, one's more rotated than the other, can give you an idea if there's a decrease of upward rotation of that scapula. The upper trap, low trap, and serratus anterior are going to work as a force couple to help facilitate some of that upward rotation. So you can definitely get your hands on them. I'll do it for sure with shoulder, like elevation shoulder flexion to see if you're getting that proper movement of the shoulder blades, but not just for the shoulder. You can look at, are they getting extension through the thoracic spine with shoulder flexion? And then for sure, you can get into it with cervical movements. You can have them, extend and see if you can kind of palpate at CT junction and down into more of the upper thoracic, mid thoracic kind of spine to see if you're getting extension at those segments or if they're kind of stopping short of that. Same thing with cervical rotation, have them rotate to the left, to the right. I usually have my thumbs just kind of resting more on transverse process and feeling for that rotation. Is there anything else that you would look at that wasn't included in the video? I know it didn't have any sound, but any palpation or observation stuff that you guys would add as well?
Hey, Michelle, in the video, obviously reading it with no sound, he's looking more at palpation as far as muscle tone. Is he looking at any rib as far as springiness, movement there with that palpation, or is that more you're doing prone?
With the ribs?
Yeah.
Yeah, and
Or even thoracic spine, I guess, for that matter.
Yeah. Let me pause this for a second. Okay. I'll palpate ribs. I'll kind of start low and work my way up to see if a rib feels more prominent. I'll palpate ribs with breathing, with inspiration, expiration. We'll get more into an actual rib assessment when we get into more of the biomechanical exam where you're actually feeling for springiness. That's also one of the kind of special tests that we'll do. We'll do like a rib spring test to make sure that this patient is safe to actually do manual work or specifically manipulations on. I think in the video, Jim is mostly just kind of palpating to feel asymmetry, is not really applying any kind of pressure to it quite yet.
Yeah, you think of that being more the biomechanical exam and the palpation exam, which is kind of further down in that book list. Or here, it's kind of the observation. It's really kind of seeing what's the lay of the land. What can I start to see and predict in the observation component? Do I see a shift in a rotation? Do I see unilateral hypertonicity? Do I see, again, a clavicle that's, level and not elevated, and a scapula that's a winging? You look for these things that kind of give you some insight into, okay, what's maybe explaining their pain pattern and what I can look for when I get to the biomechanical exam. Do I find something that's stuck, or do I find something that, from a motor control issue, is being held in that position?
Mm-hmm. Is there anything else anybody wanted to add? Any questions? Okay, we'll go ahead and move on to the next one. I'm going to share my screen again. Maybe. Okay. Can you guys see that? I'm going to assume yes.
Yes.
Okay. So we'll go into more of the active passive resisted testing. So we'll go through this a little bit more in detail as we get to the weekend course, but this is like a quick screen, and this can actually, help. This will be a big piece of trying to guide your leading hypotheses on what could potentially be going on.
Hey, Michelle, can you just put the captions on?
Oh, yeah, I'm sorry. Hang on.
Thanks.
Yeah. Okay, I'll go through that and let me start over. So you're looking for any kind of reproduction of pain. You're getting that end feel. Does it feel more, if it's a muscular or capsular kind of end feel, you're not going to feel a whole lot just with like doing the resisted testing. You're going to feel more of that capsular or pathomechanical end feel when you get into more of the pavums or the pavums. So I usually have them actively rotate first, and then I apply a little bit of an overpressure. It looks like Jim's kind of helping guide all the way through it. I do a little bit more, like I want to see how much they actively move, and then I apply an overpressure, and I'm mostly just kind of looking for reproduction of pain. With flexion and extension, so the way that Jim is doing it, he's using his guide or his hand to kind of guide down the spine. Again, I'll have them actively extend first because I want to see where they're moving through. A lot of times you'll see if they have some stiff segments going on in the thoracic spine, you'll see them hinge down in the lumbar spine, either at TL junction or getting into the lower lumbar spine. So I want to see where they're moving, because obviously that's how they're going to be moving. If they're putting something up on a high shelf, they're going to be extending through that segment. But then I'll also get my hands on them and try to guide them, see if they can actually get into some extension through those kind of upper, mid, lower cervical or thoracic segments. Rotation and side bending are going to be big ones to try to differentiate between like a rib lesion or a facet lesion or a ring lesion. And we'll definitely get more into that on the weekend course. But it's kind of nice, like if you don't feel super confident in your palpation skills, and like Eric and Dave are great at like feeling and determining like, oh yeah, this feels stiff or this feels rotated. And it's hard at first to kind of get that kinesthetic sense. At least it was for me, and it still is kind of difficult at times. Like, I'm not sure what I'm feeling. It all kind of feels the same. But you can get a lot of information just seeing how they move and how their range of motion looks. So if they're lacking a significant amount of rotation, it's maybe more likely that they have a ring lesion instead of a facet lesion. You'll get some rotation differences with rib lesions as well, but you're going to get more of a difference between rotation if it's like a ring lesion. I built or made this chart. Actually, I don't take credit for this chart because it actually came from Eric. I'm going to share my screen. Okay. So this is going a little bit off topic, but let's scroll it down. All right, I'm on my tablet. Okay, so this is kind of a good way that I'll use this chart pretty often to try to come up with my leading hypothesis. Is this a rib issue, a facet issue, or a ring issue? I can definitely share this with you guys if you would like, but we'll probably go over it this weekend anyway. So just looking at the active passive resisted exam, like I said, looking for the rotation loss, you're going to get a significant amount of rotation loss if it's more of a ring lesion versus facet. Rib lesion is going to have more of a rotation loss compared to facet. With rib lesions, a lot of times you'll have them complain something about like, it hurts if I take a deep breath. So that's, sometimes can lead you down towards more of it's a rib issue. With ring issues, Jim didn't touch on this in the video, but we'll definitely talk about it this weekend. Doing combined movements like latection and rotection. We kind of very briefly, I think, touched on it in the last module, like getting into like the AA joint, what latection and rotection is. But basically what latection is when you instigate the motion with side bending first. So you side bend and then rotate. So if I want to induce left latection, I'm going to side bend left, rotate right. Rotection is the opposite. It's when you instigate the motion with rotation first. So I would say latection tends to be more of the functional combined motions that you'll see, especially with golfers, for example. They're going to kind of get into that side bending and then kind of rotation moment. So that's a way that you can kind of differentiate between a rib lesion, facet, and ring lesion. You're going to see some significant differences with your combined motions for ring lesions. And like I said, we'll go into this more in detail on this weekend course, but just want to kind of plant the seed a little bit. Does that make sense? Do you guys understand what latection and rotection is? Eric will be able to explain it a little bit better, but what you'll kind of get is a little bit of translation in the motion when you kind of go through the combined motion. And you can kind of confirm that. Usually what I'll do is have my hand on their shoulder, and I'll have my other hand kind of on here. Let me unshare my screen. Can you guys see me? Yes.
We can. You're just smaller.
Oh, okay. So I'll have my hand on their shoulder and my other hand kind of around their rib. So the ring is the rib, the whole segment. And what you're going to do is like a translation glide, basically kind of either moving their shoulders or stabilizing at the ring, translating their shoulders over and just assessing for the motion. So that can kind of give you an idea, work your way up the spine. If one is feeling particularly kind of stiff, they're just not translating over.
Michelle?
Yeah.
So could you explain like a ring lesion versus a rib lesion then? Because I just got confused.
Yeah, so the ring refers to the whole kind of segment. So you're going to get the ribs on both sides plus the actual like segment vertebral level as well. And what you'll get is either a rotation or a translation, usually a combination of both. So it's not just the rib on one side that's, the issue, whether it's, more posterior, anterior, whatever it might be. It's the entire ring itself. And a lot of times you'll get kind of these translation or rotational lesions at a ring level, and you'll get a lot of times you can get them at multiple levels. And I think Eric kind of touched on this, that you'll get a compensatory rotation the other way, either higher or lower down or both. Eric will be able to explain it a little bit better, but the ring refers to more of the entire kind of rib segments, plus the vertebral body and all the joints, versus rib, it's just going to be more of that one side. Does that make sense?
It does, thank you.
Yeah. I think that was it that I had for active passive resisted. We'll go into more of a thorough assessment looking at TL junction. I feel like TL junction really is the death of people because it seems super complicated, and it takes just a lot of repetition to understand the TL junction. It's not something that I learned really in school at all. I don't think we went over TL junction at all in PT school. We'll go more into detail. I'm not going to get into it now because you could do a whole hour session on just TL junction. But with that, you usually look at your standing lumbar rotation and side bending first, and then go into seated, like thoracic, seated rotation and side bending. I'm not going to get into that. Believe me, Eric is going to go into a lot on TL junction, and we'll get it every single module. We'll bring up the TL junction again. I'm going to move on to, I think the next part is just going over like reflexes, dermatomes, myotomes, which is not easy for the thoracic spine because you get so much overlap. I'm going to bring this back. Neural dural testing. There are other special tests that you can do to kind of check for more like motor neuron issues. Make sure you got closed captioning. So as far as dermatome testing, really you're only going to get like T8 through, I think it's like T10, 12 as far as your landmarks for doing dermatome testing. Doing sensation at xiphoid process, that's T8. The umbilicus, that's T10. And then getting kind of into the upper groin issue or groin area. I would normally say it's kind of right where most people have, like, if they're wearing shorts, like right at their waistband there. That's going to be more T12. So you can do your light touch, your pin prick at those levels. Jim's saying, like, going into like myotome testing, you can do a test called the Beavers test. I gotta say, I think I've done the Beavers test. I can count on one hand. I can count on one finger the number of times I've done Beavers test. That's may not be what it should be, but I really have only done Beavers test. It was a patient that came in with some red flags, and I just had to go through some of these actual dermatome, myotome reflex testing. Just something didn't seem quite right. So xiphoid process is T8, umbilicus is T10, upper groin area is T12. It's very unusual to get some sensation differences in these areas, but it's definitely an option, especially if you're getting a patient that's coming in with some red flags. Doing pin prick. Okay, so yeah, nothing really super complicated about that. Again, I think I've only really done dermatome testing for like the thoracic spine once. And again, that might not be what is recommended. I'm just being completely honest. And it was a patient that had a positive thoracic slump test. That's where I kind of had to dive into a little bit more of their neurologic kind of testing. We'll go in, I'll kind of touch on it today on safety tests and what the thoracic slump test is. But yeah, he had a positive thoracic slump. So that made me kind of have to dive a little bit deeper into some more of these upper motor neuron issues. We'll look at reflexes next. Oh, shoot. Okay. So reflexes, you can look at the abdominal cutaneous reflex. It's basically just kind of stroking this, like, over the skin. You divide the abdomen into like 4 quadrants. And I think, yeah, Jim's using like the end of a reflex hammer. You're just stroking the skin. And what you should see is that the umbilicus will deviate towards the stimulus. So a positive is if you don't see any movement at all. And it's very, very subtle. Very, very small amount of movement that you'll see. Beaver's test we'll get into, I think, in the next video. Looking at your long cord reflexes, deep tendon reflexes, Babinski, clonus, deep tendon. So what you're looking for is hyperreflexia. It's different than having a brisk reflex. A lot of times they'll feel almost like it's like clonic, jerky. You might get added beats. So it's a little bit different than just like your brisk reflex that you'll get with a facilitation. Looking for clonus. Was it more than 2, 3 beats that is a positive? I think it's like 3 or more is positive. I'm going to scroll down. This is the Beavers test. So again, you kind of divide the abdomen into 4 quadrants. And what you want them to do is basically like lift, let me turn the captions on. Lift their head up, and you're looking for how the umbilicus moves. What you should see is symmetry. Now, a lot of times you'll see the umbilicus kind of move a little bit superiorly, but you're looking to see if it's being pulled more one direction, more in one quadrant versus another. So it's subtle. If you do a full crunch, you're obviously going to see a lot of more of that kind of superior motion of the umbilicus. So it's just really lifting the head up, and you're looking for the very initial movement of the umbilicus. It's like really subtle at the very start, and you're, like I said, you're just looking to see if it's being pulled more into one quadrant. That's saying that there's an asymmetry going on in those abdominal muscles, where it's being pulled more towards one side, not being activated on the other side. So having her just lift her head up. Or maybe it moves more downwards. It could, I think, can move upwards or downwards, but you're again looking for that very initial movement and to see if there's any kind of asymmetry. Again, I've only done this on one patient ever. You can check the intercostal muscles as well. Basically, you just kind of wedge your fingers in between the ribs and feel for the intercostal muscles like activating. See how far your fingers can kind of sink in. If your fingers sink in on more on one side, you got some weakness going on at the intercostals. To me, that's kind of hard to feel. Sometimes you get patients that are just kind of bigger patients too. You're not going to be able to wedge your fingers in between the ribs too well. Well, you can have them hold their breath, and that's when you can kind of palpate to see how deep your fingers. Let's see. Okay, let me stop this. Oh wait, I think we have one more. Any questions on those so far? Okay, I think there's just one more. Prematurely stop that. Which one is this one? Oh, getting into more of the dural test. Oh, closed caption, sorry. So Jim's gonna take her through a slump test. Eric's gonna teach us more on doing a thoracic slump, where basically you keep the thoracic spine in neutral. So you have them flex into the lumbar spine by having them rotate their pelvis, but then you keep the thoracic spine in neutral. So you flex the cervical spine, you keep the thoracic spine in neutral, have them flex through the lumbar spine, and then straighten out both legs. So Jim's doing it like a full slump, so he's getting flexion through the thoracic spine. We'll use it as a safety test because what you're looking for is any kind of reproduction of either lower extremity kind of symptoms, or you're looking for reproduction of either chest pain or groin pain. So when you do a thoracic slump test with the thoracic spine being held in neutral, you shouldn't really have anything going on that's going to reproduce their thoracic pain or symptoms. So if they're getting referral pain into the groin or into the chest, just with flexing the lumbar spine and flexing the cervical spine, it might be more due to kind of dural tension. When you flex through the thoracic spine, obviously that's going to change the mechanics of, ribs, facets. So you can get referral pain into the chest, but you shouldn't expect to see that if you keep the thoracic spine in neutral. So that's one of the safety tests that we'll go over. The other 3 safety tests that Eric will touch on this weekend, doing like a rib spring. See you, Dave. Oh wait.
Sorry, I was just commenting that using those tests are very valuable.
Basically, just making.
Can you hear me?
Yeah.
Yeah. It's like those tests are valuable because you are going to bump into the patient who have positive slump tests and symptoms that'll appear more somatic or dural in nature. And it's going to be a segmental issue in the thoracic spine. And once you kind of figure that out and you treat the thoracic spine, you'll manipulate the joint, mobilize it, traction it, and those symptoms will go away almost immediately when that's the case. And it has to do with the tension, the dura, and how tight it's bound in the thoracic spine. So it's kind of a cool thing as you get into this testing. It's not always about looking for, do I have a thoracic disc or a cord problem? There are some mechanical issues that will present and have that kind of positive. So this testing is very helpful with that. Okay.
Yep. Yeah. The other safety test we'll go over a rib spring test. Basically, you have the patient lie supine and you put pressure through their sternum, and what you want to feel is that springiness. For female patients, you can have them, basically the patient have a fist on their sternum, and you can basically just kind of press through their fist. And like I said, you're feeling for that springiness. A positive test is just that lack of springy end feel. You'll sometimes get that with patients that have like RA or ankylosing spondylitis, and you need to be a little bit extra careful with those patients. You don't want to fracture anything. The other 2 tests that we'll kind of go over, the posterior shear test, you have the patient sitting. Basically, you get a key grip right on the articular pillars and you try to shear it forward. And what you should feel is nothing. You shouldn't really feel all that much movement. So you're checking for any kind of instabilities there in the thoracic spine that would be a contraindication for a manipulation. And the last one is just checking upper motor neuron signs. So doing your Babinski, your Oppenheimers, your deep tendon reflexes, clonus, looking for any kind of those upper motor neuron signs or symptoms. So Dave kind of mentioned a thoracic disc herniation. What else could potentially give you upper motor neuron signs? Anybody can answer. I don't want to call in anybody. Somebody, I mean, one other thing that could potentially cause upper motor neuron signs or symptoms.
Could it be like stenosis in the spine?
I guess it depends on how significant it is. If they're actually getting that myelopathy, I guess, yeah, if it's severe enough. Any kind of space occupying lesion, a tumor, for example, that can definitely give you some upper motor neuron signs, even like MS. What's interesting about like if any kind of space occupying lesion, a lot of times it's slow growing, so you can get palsies going on, but not necessarily with pain. So that's kind of a big red flag. If you're taking them through a thoracic slump test and they're getting a palsy somewhere in their legs, they're not able to dorsiflex, but they don't really have any pain with it. That's kind of a big red flag, and like something's not quite right here. I think Eric will probably share a story on how they actually found that in one of their models from one of their mock exams or one of their exams that they take. He actually had some sort of cyst or a space occupying lesion, and he came up as like a positive thoracic slump, positive upper motor neuron kind of sign, but he didn't have any pain because it was slow growing. I don't I can't think of anything else that might cause some upper motor neuron signs. I'm sure there's more out there, but I can't really think of any. Does that all make sense to you guys? Do you guys have any questions at all? So that's kind of basically what I look at in a very quick thoracic scan. You know, check posture, do your observation kind of exam. Obviously, you're going to take a subjective history, so you're looking for red flags there. We talked last Zoom session on how to differentiate if it's more of, potentially a cardiac issue that might be presenting like it's either a cervical issue or a thoracic issue. It will start at kind of that T, I think it's like T4, and that's how you'll get your chest pain, your chest wall kind of pain. It feels more like pressure. That's often what patients will kind of describe it as, but you'll get a lot of variation. And it'll move up the chain to the point where we'll kind of get into the lower cervical segments, getting into arm pain, getting higher up into the upper cervical segments where you'll get jaw pain. Usually you'll get some other symptoms along with it, like nausea, dizziness, things like that. But it's so variable. I remember when I went through this course, I think it was maybe like module 7 or 8, and Matt or Eric gave me a case with my partner, and it was a patient that had radiating pain down the arm, but she also had jaw pain. And I totally dropped the ball. My mind immediately went towards it's a cervical issue, maybe 2 cervical issues, one like mid or lower cervical for the arm pain and one upper cervical for the jaw pain. And Eric's like, this doesn't like this is do you feel comfortable with your hypothesis? It's like, yeah, I feel pretty confident. And he's like, well, I don't. So it's easy to kind of get fixated on a hypothesis, and you got to keep in the back of your mind that this may potentially not be something that's musculoskeletal going on. It's not always super obvious where you're like, oh, I have this chest pain and I'm having difficulty breathing. It's just getting shooting pain down my arm. Yeah, I have blood pressure issues. Obviously, that's going to be questions that you're going to ask either in your subjective exam if if they're getting other kind of signs or symptoms. But you want to look to see, are they getting their symptoms reproduced with exertion? How long has this been going on? Is this like a free assessment that's walking in that started earlier this morning? Or is it, this has been going on for months? But yeah, you got to keep it in the back of your mind that it's very unusual to get something like that will walk into your clinic, but it can happen. I feel like that was really it that I had for you guys.
No, you had a case.
Oh, I did have a case. So this was it was a free assessment that came in 2 days ago. I want to preface this first by saying it was Halloween, and our clinic has a bank of windows, floor to ceiling windows, and it's like 2:00 in the afternoon. And I see this guy walking across the street in a full out dinosaur costume. And I verbally said out loud in the clinic, I was like, oh, look, the first trick or treater. 30 seconds later, this guy walks into our clinic. He was a free assessment. So this guy came in, he came back, he sat down, I sat him down, and we had a full-on conversation. And I was like, tell me, he's coming in for thoracic pain. And he didn't mention his costume at all. It's like full-on hood up, tail and everything. I was just like having a hard time taking this guy seriously because he came in a dinosaur costume. Anyway, beside the point, although I don't know what kind of dinosaur it is, but it's the one that has like the spikes down the spine. I had to tell him to take it off because his got in the way of his spine. But anyway, this guy came in. He came in with like right side mid back pain. He said it started about 2 weeks ago. He went on vacation. He was picking up the luggage to put it over in the overhead bin, or maybe he was, I don't know, in the airport and picking and rotating his back, and felt very, very sharp pain in his back, to the point that he said he was down on the ground in the airport and had a hard time breathing. He couldn't really move at all. He was eventually able to kind of get into his seat on the plane and make it home. And he basically was on bed rest for the next like several days. He said he had pain with any kind of like deep breathing at all, any kind of rotation, lifting his kids. He's got 2 young kids. So, it was a free assessment. So it's a really quick exam. It wasn't actual an evaluation. But, my mind kind of went to the big 3 kind of hypotheses. Like, is it a facet issue? Is it a ring issue? Or is it more of a rib issue? The fact that he said that it was very, very sharp pain with breathing, that kind of made my rib idea a little bit higher than the other 2. But obviously you couldn't know for sure without actually doing a biomechanical exam. So his rotation, so he came in with right-sided pain. He had pain and limitation with rotation to the right. Left was minorly limited, but not painful. Flexion felt fine. Extension looked kind of just stiff a little bit throughout his entire thoracic spine, but it wasn't anything it wasn't painful. So what other things other than kind of like a rib lesion? I already said facet and ring. Is there anything else that you guys would kind of throw in there as a hypothesis? Anything? I guess you could maybe throw in there muscular, but just from the mechanism. Um, what would you guys look at? I guess what would you expect to see with more of a rib issue versus facet versus ring? And you guys may not know the answer to this because we haven't really gone over it.
I mean, with facet, to me, you're gonna have more pain as far as with just true extension, in my opinion.
Yeah, probably, especially in this early phase when it's still pretty flared up. By the time he saw me, it was significantly better. But anything that might kind of, close down those facet joints, especially in the early phase, is not going to feel super good at all. Sometimes it's irritated enough that flexion is not going to feel great either. With facet, you may see kind of a limitation in that flexion or extension. But yeah, I would definitely probably expect that he would have some pain with that extension. And he said it was minorly kind of iffy, but it wasn't too bad. The other thing that you can look at is, for him, it was a little bit more of a mid thoracic kind of issue. Kind of looking at, it was more like T5, T6. You may potentially get some irritation with cervical range of motion, cervical rotation. For him, he said that it was a little bit painful. It was a little bit limited with rotating, cervical rotation to the right. But you're going to really kind of figure out, especially with your biomechanical exam, going through seated like pivums, pavums, where you kind of palpate down, just how we did for the lumbar spine. You can kind of work your way down, see if one transverse process feels a little bit more posterior versus the other. And then you can apply your pivum, put a little bit of pressure, see your end feel. Is it a subluxation issue where it's not moving, or is it a hypermobility going on potentially on the other side? So that's going to kind of give you a little bit more of a guidance. Is this a facet issue? With ribs, we'll get into the weekend doing some prone kind of glide testing. And that's kind of what I felt with him. What was tough is that this guy, he's a free assessment, so technically you're not allowed to actually do any treatment. You can kind of suggest doing like exercises, but it wasn't really. Kind of was a tough decision. Like, do I go ahead and manipulate this guy, even though you're not really supposed to do that in a free assessment, or do I wait for him to come in for an evaluation? This is probably what you probably shouldn't have done, but I went ahead and just manipulated him because he said he's going to be out of town for the next several days and he wasn't able to come in for an evaluation until like Tuesday next week. And to me, it's just like I was already there. So I went ahead and did like a traction or distraction kind of manip for the rib. If you're not really sure what position the rib is kind of stuck in, we'll learn techniques like a distraction kind of technique that could encompass really if it's whatever way it's subluxed. And for him, I mean, I followed up with him yesterday. He said he was feeling really good. I gave him some mobility exercises to work on, but hopefully that manip was enough. And he did have some other issues going on. He said he's had some like Achilles pain for the last year. So he's actually coming back as an actual evaluation later on next week. But hopefully, that thoracic spine is clearing up enough. We'll probably do some like movement pattern kind of mobility stuff, but hopefully that was enough to kind of take care of it. Do you guys have any questions or any patient cases that you want to talk about? I know we only have like 5 minutes left.
Yeah, it's a pretty common case, isn't it? I'll go ahead.
I've had a few with like this like mid like thoracic pain on the right, and it's like they get it with like scap retraction, and I was talking with my coworker about it, and it seems like to be like they have like a full like thoracic rotation due to like prolonged desk sitting and like where their camera set up with Zoom and everything. A lot of people that like, and they're both the two I have right now. It's like both when they like do a scap retraction, they get this pain like mid thoracic, and I've been doing like METs and like treatment to the rib, neck, and like the one I was treating the shoulder, and then it like wasn't helping, so I went down to the back, and then that was helping, but then it like came back, and then it went back to the neck, like while treating the like thoracic with all of them. But I like struggle with like trying to treat just like that full like rotation that's going on from the like prolonged sitting and the pain, like that mid thoracic pain that just doesn't go away.
Yeah, and sometimes they can just get like myofascially wound, so it's not like it's like one specific spot that's the issue that's kind of mucking everything else up, but it may be kind of more of like they're getting like ring on top of ring on top of ring. If they always have the monitor towards one side, they may just be kind of more myofascially wound that way. And you may not, maybe manipulation is not necessarily the best thing for them if it's more of like a capsular kind of infill, working into movement patterns kind of stuff too. Obviously, changing the way that they're sitting at the desk is going to be big if they're. It's kind of hard if they have more dual monitors and they use one monitor more than the other. They're probably always going to be a little bit rotated, but trying to kind of change their positioning a little bit so they may not be more rotated one way all the time. Dave, I'm not sure if you had anything else you wanted to add with that one.
Yeah, no, it's like with that one, that's where you get into the biomechanical assessment, kind of where Chan was when we were in the observation, is that I want to know, okay, is this something that's stuck? It could be hypermobile, or it could just be positionally stressed and wound, if you want to think about kind of the different motion states of what a joint will be. Because, it could very well that, okay, they're levering through this because they've created, I hate to use the word instability because it's just used so much. It's tough to kind of nail it down to a meaning, but let's call this functional instability in a sense where they're twisting through this to create an expanded neutral zone at the facet capsule or the costotransverse joint. So that becomes irritable rather quickly because it's always going too far. And they need to be kind of brought back to a center neutral. And then, again, muscle retraining to try and kind of, again, shore up the area. If you're lucky, it's subluxed. You manipulate it, correct the postural fault, and you're kind of good to go for a while. I would again agree that, I say that, but what I do then right after then is try to get them to make sure they do the neuromuscular retraining afterward to make it stick. Because you manipulate it, they're usually good immediately, but if they don't change the faulty pattern or change the motor recruitment patterns, then you don't get as good stickiness. So as I say, what we teach you when you learn the manipulation, it's the shortest, easiest part of your treatment. Then it's getting them to do the buy-in on the neuromuscular re-ed and the retraining. Cool. Great job, Michelle.
Thanks, Dave.
Great. Michelle did so good that we decided we were going to make Michelle do all these going forward.
Hell no.
I want to make sure I can see your face. Yeah, okay, I can see your face in the sun.
Yeah, I wouldn't count on me joining any Zoom session after this then.
Yeah. It was like offering Michelle for sacrifice. I felt like, I was giving her away up for adoption. But hey, no, you did a great job. Thanks,
Dave. All right, I'll see everybody tomorrow, I guess.
Dave, are you gonna post the hour by hour?
Hour by hour. Oh yes, I have Eric's hour by hour. I will get that up for you when I get back to the hotel.
Okay, and also it looks like someone asked to post the videos as well. Like,
yeah,
I guess
Dave,
the recording
Zoom videos from the last 2 weeks.
Zoom videos, yes. Let me go through my Zoom video log. Yeah. Thank you. I'll be in my hotel tonight, so I should get a chance. All
does that mean you're in Chicago, or does that mean you're somewhere else?
No, I'm actually in Austin.
Fine.
There's the private practice session conference down here, and I'm looking at a few things. Actually, I'm meeting with a vestibular. I'm meeting with 360. We talked about it with 360 Nora Health. I'm actually outside their office. I'm meeting with them next because we're looking at kind of how do we integrate our content to kind of bring in the concussion vestibular side, meld it with some of the upper cervical material. We're looking at doing a kind of a vestibular needling course. So I'm here to meet with that. So it's fun. Be good.
Cool. All right. Thanks, everybody. Cool. I'll see you guys.
Hey, great job.
Thanks.